Good morning, afternoon or evening, wherever you may be, to our global audience. I'd like to welcome all attendees to this WSAVA Hot Topic webinar, which is intended to provide a timely update on the impact of COVID-19 on your patients and staff. My name is David Sutton. I'm a veterinary surgeon and work as Global Technical Director for MSD Animal Health, known as Merck Animal Health in North America. It's our very great pleasure to be able to support and sponsor this webinar today. And before I introduce the presenters, there are a couple of things I just want to point out to the audience. Although this presentation will be in English, there are additional language real-time captioning text options available. If you click on the speech bubble icon in the lower left-hand box of your webcast platform screen, you should have access to those. The other thing is to do with questions. There should be some time for questions following the presentations. And although you'll be muted, as is usual for these types of webinars, you're encouraged to submit any questions using the Submit a Question dialog box, which is actually the lower right-hand box on your screen. If you just click on the question mark icon and type in the question, then that will come to us and I will be moderating and asking questions on your behalf. Please feel free to submit questions at any time during the presentations. So let me introduce our presenters for today. We have three presenters, Dr. Michael Lappin. Dr. Lappin graduated from Oklahoma State University and then completed an internship in internal medicine residency and PhD program in parasitology at the University of Georgia. His principal areas of interest are prevention of infectious diseases, the upper respiratory disease complex, infectious causes of fever, infectious causes of diarrhea, and zoonoses. Dr. Lappin is the Kenneth W. Smith Professor in Small Animal Clinical Veterinary Medicine at Colorado State University, and he helps direct the shelter medicine program there. Dr. Lappin is the director of the Center for Companion Animal Studies. And recent awards include the Norden Distinguished Teaching Award, the European Society for Feline Medicine International Award for Outstanding Contribution to Feline Medicine, the WIN Feline Research Award, the ACVIM Robert W. Kirk Award for Professional Excellence, and the WSAVA Scientific Achievement Award. And Dr. Lappin is the chair of the WSAVA One Health Committee. Next, Dr. Squires. Dr. Richard Squires leads the Veterinary and Clinical Sciences team at James Cook University in Townsville, Northern Australia. He's a diplomate of both the American and European Colleges of Veterinary Internal Medicine, and he holds the Royal College of Veterinary Surgeons Diploma of Veterinary Radiology. Dr. Squires held faculty positions at the Universities of Liverpool, Pennsylvania, Wisconsin, and at Massey University in New Zealand prior to taking up his current position in 2007. Throughout much of his career, he's taught and assessed veterinary students in the broad discipline of canine and feline internal medicine. Most of his research has been on canine and feline infectious diseases. In addition, for 5 years in New Zealand, he taught and carried out research in veterinary virology. Richard was a member of the World Small Animal Veterinary Association's Scientific Advisory Committee from 2008 to 2020 this year, and has been a member of the WSAVA Vaccination Guidelines Group since 2012. He's currently chair of the WSAVA Vaccination Guideline Group. And finally, Dr. Peter Karczmar is a board-certified specialist in pulmonary and sleep medicine. He's a medical doctor. He's also board-certified in internal medicine and critical care medicine. Dr. Karczmar is active on many committees at Coastal Medical and the Miriam Hospital, where he works, and has served as medical staff president through 2012. He's also the recipient of several awards for excellence in teaching at the Warren Alpert Medical School of Brown University, where he is clinical assistant professor. These include the Internal Medicine Residency Program Teaching Award, the Dean's Teaching Recognition Award, and the Beckwith Family Award for Outstanding Teaching. So certainly someone who can teach us very effectively in this particular area. Dr. Karczmar is a member of the WSAVA One Health Committee, and he has a strong connection and understanding of the veterinary world, as he's married to a veterinarian and practice owner. So he's ideally qualified to talk about the impact of COVID-19 on veterinary practices. So without further ado, I'd like to hand over to Dr. Michael Lappin to start the presentations.
David, thank you so much for those introductions. I thought we were just going to do the Mike from Colorado type introduction. So thank you so much for sharing all those great details. Gosh, it's so exciting to be part of this really great team. Gotten to work with Richard and Peter many times over the years, with Peter also being on the AAFP, the feline group zoonosis guidelines panel with me. So again, I did want to acknowledge all the people that work at WSAVA to help us put this together, and again to re-acknowledge the sponsorship of MSD of our work. The One Health Committee has been a little bit active here recently with the global pandemic that many of us never thought we'd get to see. And certainly the vaccine guidelines group with Richard's leadership after the loss of our friend Michael Day. It's also been great to have the input from the scientific committee with Mary and Frederick and so many people active in WSAVA trying to keep accurate information available to our constituents around the world. So again, very pleased to be able to do a brief update today on the animal associated, the four-legged animal associations with SARS-CoV-2. So with that kickoff, I think we would look at this virus as being pretty interesting in that it can jump species. When we update the animal part today, and I thought I'd just get it off the plate right now, this is a reverse zoonosis, primary disease of people. It can jump to some other species. And what we'll talk about in the clinical discussions today is then whether or not it can then go to other species. So that'll be my little part in this first 12 to 14 minutes. And then we'll pass on over to Richard, who can give us the updates on preventative health impacts with this pandemic. And then finally with Peter, as we've discussed, having the physician's viewpoint. So please don't be shy about those questions. I know the three of us would love to be able to share our opinions. So just a regrounding background slide. We are used to working with coronaviruses as small companion animal people. Again, we've had our love-hate relationship with FIP, the feline infectious peritonitis, and the enteric coronaviruses. Great kind of comparative information towards the end of my talk that perhaps some of the great work that Niels Peterson and others have been doing with nucleoside analogs would potentially also cross over to treating this beta coronavirus, the human SARS-CoV-2. Again, many of us were veterinarians with the first SARS back in the early 2000s, and then obviously the MERS outbreak that was a few years to follow. But nothing's quite been as dramatic, at least in the coronavirus world, until SARS-CoV-2. And so just again for terminology, the virus is the coronavirus, and the syndrome that it induces in people has been termed COVID-19. I was always laughing about, what were you doing when a big impact happened to the world? For this one, the Wuhan outbreak starting, little post way back in December now. And it's just amazing how we now have had, over 28 million people infected with over 800,000 deaths. So we know this is a true global pandemic that unfortunately is not finished at this stage. A lot of writings on the Hong Kong group, and again, regards to Vanessa Bars from Hong Kong that was able to keep us informed, the rest of the Hong Kong team keeping us informed with those great reports of the dogs and then ultimately cats that had been held in isolation in their system, allowing for some repeated testing. So, gosh, I don't know if any animal in the history of mankind has gotten more attention than those first cases in Hong Kong. Our One Health Committee, when we write our e-shots, which we'll have one coming soon from Mary, myself, and our teammates at the Center for Disease Control, I think all of us, every time a posting came of the next animal that was positive, there'd be a flurry of activity with press releases, et cetera, et cetera. Each of these animals that's positive is still notable. However, I think the novelty of an animal that was exposed to a sick person potentially becoming positive, that novelty is gone now. We know this is a reverse zoonosis. And thanks to our friends at OIE for continuing to maintain that listing of each of the animals. And you can visit the website and evaluate each of those cases yourself. Pretty good information for most of the different confirmed positive results from around the world. And thanks for OIE for having Dr. Torres on our committee on the One Health side. We talk about the context when we think about, well over 28 million people now with only, you can count on your 2 hands and 2 sets of toes, the numbers of positive proven companion animal cases. That does seem in contrast quite striking, but we do also have to factor in that we haven't had a chance to systematically test as many animals as people. And so the ratios, I'm sure, are still quite lower, with companion animals being quite unlikely to be infected unless they're in the home of an infected person. But as we'll see now that we're getting more information from experimental studies, it's actually not quite as easy to infect some of these companion animals as we thought. And when they do become infected, and sometimes with some clinical manifestations, the good news is it generally has been self-limited, with shedding of the virus stopping very quickly. So again, big contrast, 28 million to less than probably 30 overall dog and cat cases proved. I think one of the key points that the One Health and Welfare Committees from WSAVA wanted to get across today, and I'll just summarize it on one slide. This is a human virus that occasionally infects a dog or a cat. Still no significant data other than perhaps the mink outbreaks that it goes from the pet to the next human. And so please don't be fearful of animals, especially well animals. The odds of them carrying this virus at levels that would infect the next human seems to be quite low. And so it's truly an animal welfare issue when we have a frightening virus, I grant you that. But again, back to the odds of that pet being dangerous. So right now, I think, gosh, since the beginning of the pandemic, guidelines around the world, including those from the Center for Disease Control, is basically just sequester with your pet, stop the snuggling for the time periods that you're sick and for that next 10 days or so, and hopefully everything will quiet down all on its own. No need for relinquishment, no need for fear, and certainly always be kind to small companion animals. Yes, the mink data, concerning, and I know it got a lot of attention, but remember, mink farms, fairly crowded, lots of animals, lots of manure, probably initiated by people to the mink to begin with. The genetic link, the potential that the virus strains that were in mink and persons might have suggested that there was a transmission back to a human. Plausible, but with the levels of virus that we're seeing in companion animals, hopefully not likely. So still really a reverse zoonosis, not a direct zoonosis from four-legged to two-legged animals to our knowledge. So congratulations to the researchers around the world that have been able to start publishing small experimental studies because it will take us time to learn from the field cases exactly the extent of this viral infection with the small companion animals. But what we've been learning then with the experimental studies, usually 1 or 2 strains have been used that are available to researchers right now. What we've learned with the small companion animals is that, yes, cats can be infected experimentally, and those cats that are infected then can pass on to a cat that's passively housed with it with short-term viral shedding. So this one small report just published a few months back now pretty much confirmed that that shedding rate should be quite low, and back to the sequester at home or quarantine at home, the shedding, if is occurring with an exposed cat, should stop fairly quickly. This work has recently been published as well as a preprint. So always remember that preprint. BioRxV is a preprint association of literature, so there may be some changes by the time these papers make it into the final stages of publication. But they're a great way for us to all have access to this information to make our own critical reviews. And so that work has come from Angela and Dick Bowen's group here at Colorado State. And it's been quite interesting to get to be part of that in our kind of COVID meetings here in Fort Collins, Colorado, to hear the information as it's coming. Again, corroborating results of others, a cat can be infected, infect then in contact cat. But this work also has now started defining serological responses, and Sue Vanderwood's group looking at different best antigens versus doing true virus neutralization type antibody tests. And the good news is cats and dogs, depending on the assay that you're using, do make very robust antibody responses. And in Angela's recent study, when they re-challenged some of those cats, they were actually strongly immune to reinfection at that 28-day mark. Very interesting in our dog work, those dogs seroconverted, so their immune system saw the virus, but they did not shed live virus at all. And so that's a good news overall if that's the rule with animals that are exposed. You might have seen last week's posting, the discussion of the great work that even though we know on ACE2 receptors, the early work that helped us determine what species might be predisposed or permissive to this virus, ferrets had been on that list. Ferrets can be infected experimentally. But then in this group of reports, ferrets living with people with COVID-19 clinical manifestations were actually unlikely to become infected. So the good news is the body of work to date, which needs to continue to grow in good scientific, systematic ways, the work to date suggests that dog and cat, ferret, probably the rabbit, all can be infected if exposed. Disease has been quite mild in the experimental animals, which are generally young adults or young animals that are healthy otherwise. And so field cases with other comorbidities, perhaps there would be more significant illness. But the good news is with the limited amounts of surveillance we've been able to do so far, it does appear that it's probably going to be a pet that's with a person that has COVID-19. It's probably going to all be over for that family with the shedding, et cetera, within that 10 to 14 days. And so hopefully that household will then be the end of that particular little endemic area for that family. And as we then explore things like unexplained outbreaks in the United States of just regular kennel cough, some of the work that we've been doing in our lab, so far it hasn't been one of the major causes. We've had 0 results that were positive. And then one of the insurance companies that does work with WSAVA, the Trupanion group, they've been watching for spikes in claims for either respiratory or gastrointestinal illness and haven't found those. And so one of the biggest controversies, as I wind down to turn over to Richard here in a couple of slides, one of the biggest controversies that has kind of hit the internet the last few weeks is, I hate to say the word criticism, but questions about why can't we test more animals, et cetera. And again, that is regulated in many countries. There are different rules in different countries. Since we're a global community today, your country might be different than the United States. But we do have to have permission to test animals, and then those positives then get confirmed by our national group. And so we will gather more data over time. We do have access to the research tools. More information will be coming. Hopefully we'll see you either via the e-shots or continuing webinars in the future with further updates on animals. And so then lastly for me, right now, we're not even sure we can confirm a positive dog or cat before their clinical signs are gone. So honestly, specific treatments for dogs and cats seem to be probably unnecessary at this stage, since most of them have had mild to no disease whatsoever. But the exciting part, of course, is we now have that opportunity that drug discovery for both people and animals will continue to be active in this field because of some of the similarities and some of the activities of the drugs that we're excited about now for our feline infectious peritonitis, also potentially helping people, which Peter will talk about a little bit later in the human side of this lecture. But thank you very much for the opportunity to give that update. Richard, I think that it's probably time that we think about how we can still prevent all those other infectious agents that are probably overall a lot more common than SARS-CoV-2.
I agree. Thank you so much for that superb bringing us up to date there, Mike. Really enjoyable and interesting. So I have a relatively small number of points that I want to make, but some of them are important. And let's get into it. So we're going to talk about the priorities in veterinary preventive healthcare for dogs and cats under these conditions in which we find ourselves. And most of the time, I'm going to be talking about routine prophylactic vaccines. But towards the end, I will say just a little bit about some other things in terms of parasite control measures and other preventative healthcare monitoring activities that have been disrupted by this pandemic. So prioritizing is key. I was really quite impressed by the WSAVA's advice or guidance on the use of vaccines in dogs and cats, because they really were using this word prioritizing to a great extent. And we do need to decide what our top priorities are. Of course, the Vaccination Guidelines Group has always talked about the need for risk-benefit analyses when particularly using non-core vaccines. Every animal's an individual, every situation is an individual situation, and we have to decide whether under those circumstances the use of a non-core vaccine is justified. And now we're in this world where there's almost like another dimension of need for us to carry out risk-benefit analyses. It's no longer as simple as thinking about the lifestyle of the animal and what it might need in the way of vaccines because of that lifestyle. We also now have to think about the important vaccines, the most important ones that even under these circumstances, we might need to prioritize and provide for the animal. So it reminds me very much the way we're now having to think of triage. I first encountered that word triage when I went to work in Philadelphia and I was working in the emergency room, and I saw the nurses sometimes taking the students with them to go into the waiting room to triage the patients and decide which one was dying first. And what was really important to me to notice and relevant to this discussion is the fact that circumstances changed everything. If the waiting room was relatively empty, then an animal that perhaps wasn't very sick would be brought out back straight away. But if it was absolutely teeming with severely ill animals, different priorities were in play. So I think what we recommend about the use of prophylactic vaccines and other preventative healthcare measures is going to change, and it's going to depend on how long this goes on. I live in Australia. I live in the northeast of Australia, and our Prime Minister is really driving the states and territories, the premiers of the states and territories, to open up and get cracking and get engaged in economic activity earlier than some of them want to. They can see the vote getting power of being extremely cautious, in the case the Premier of the state I live in, Queensland, being very vigorously protective of Queenslanders. But I think that if this goes on for very much longer, then what we're going to see, I think, is that some of the priorities are going to come to the fore. So the BSAVA, I mentioned before, in their document, talking about prioritizing what we should do, they keep saying, if this goes on for 2 months, you know, is this important? Do we need to do this in the next 2 months? Will the animal suffer if we don't do this in the next 2 months? Well, if this goes on for another 6, 9 or more months, then we're obviously going to need to triage the situation and behave appropriately under those circumstances. But the good news is that there are some fundamental priorities which have got more to do with the nature of the vaccines and the nature of the diseases against which they protect that will remain true throughout all of this. So let's have a look at some of that. Down in the south of Australia, until literally the last couple of days, you were still allowed under stage 4 severe lockdown circumstances to take your animal to the vet if there was a genuine animal welfare issue. I think that did not include preventative healthcare measures. They were talking about severe, acute, perhaps injuries, that sort of thing. And they, in support of that, they talk about taking the animal to the nearest provider, perhaps not to your regular veterinarian, but to the one that is closest. Well, this has relaxed literally in the last couple of days, and so veterinary practices are now operating in a slightly closer to normal set of circumstances. So the advice that the WSAVA is providing via its purpose-designed page is generic in the sense that it relies upon those fundamental principles that I was talking about a few moments ago. My friend Michael Day, that Mike was mentioning a moment ago, very sadly died earlier this year, the former leader of the vaccination guidelines group. Michael very quickly wrote a set of advisory notes about the use of vaccines under COVID circumstances, which I think has stood the test of time because it is really reliant upon those fundamental principles that I was talking about. And I think that was a really very substantial contribution, and it's readily available via the WSAVA portal, the COVID-19 portal. So getting into the meat of it, what should be our top priority based upon these fundamental principles that I've been talking about? Well, I think it's the youngsters and core vaccines. People are still buying puppies. They're in fact buying puppies in remarkable numbers because of lockdown. And these puppies need to be protected. One obvious way that one can protect them is to sequester them. If we're in lockdown, then we can have the puppies and kittens in lockdown with us too. But the problem with that is we're not giving them an opportunity to see the world, to socialize during that sensitive period for socialization. So when a practice is allowed by the local authorities to begin to carry out preventative healthcare measures like vaccination, I think the top priority in the vaccination realm is making sure that these youngsters are protected. And as many of you, most of you, I think, would know, all the large organizations that have produced guidelines talk about core vaccines that every puppy and kitten should receive and every adult animal should receive, so it's protected throughout its life. These youngsters need to receive, at the very least, these core vaccines. So in puppies, we're talking about distemper virus, parvovirus, and adenovirus, plus rabies in those parts of the world where it's endemic. In kittens, we're talking about the herpes virus, calicivirus, and the parvovirus or panleukopenia virus, again, plus rabies if it's endemic. We really need to protect these youngsters. Now, the number of vaccines that they require depends upon the kind of vaccine that we use and a little bit upon the species as well. So most of you, I suspect, are using modified live virus vaccines in your puppies and perhaps in your kittens as well. And a single dose of a modified live virus vaccine is protective if it is given after maternal antibodies have waned sufficiently. And a sort of safe figure to choose is 16 weeks of age. For those core agents, by 16 weeks of age, maternal antibodies should have waned to the point that the animal can be successfully immunized. So if you're in a tight lockdown situation, that is the most important figure to remember, that that vaccine, the 16-week vaccine, would need to be given to protect the animal. Now, in kittens, particularly because of the respiratory viruses, the recommendation is that even if you're using modified live virus vaccines, they should receive 2 doses, 2 to 4 weeks apart. And for those of you that are using killed or inactivated vaccines, you definitely need to go back to the old notion of prime boost. You really do need to give at least 2 doses to prime the immune system and then boost it subsequently. So if you're in a situation where you want to minimize the number of visits, then modified live virus vaccines may be the way for you to be able to achieve that. So after that, what needs to be done? Well, the animal needs to be boosted, or actually what we're aiming to do is to catch a small minority of non-responders who, even though they received the vaccine at the right time, may not have been immunizable. And we're recommending that that be done at 26 to 52 weeks of age. And if any of this requires you to use vaccines in a way that is not in agreement with the product label, then you should talk to the owner and obtain informed consent. So that's the top priority, protecting the youngsters, give them a good start in life, and protect them against those core diseases. Now, this is something we must not forget, this notion of, I mentioned it briefly, the socialization, the critical period for socialization. Varies slightly what people say about its duration, but approximately 4 to 16 weeks of age. This is the age range in which as many experiences should be provided to the puppy or kitten, so that they, particularly puppies, so that they don't become fearful, anxious individuals. And the good news is that a number of websites have got excellent advice about how one can still do a serviceable job to socialize or to prepare the puppy for a life, even though we may be in lockdown. Obviously, we can keep the animal in our garden or in our house most of the time. We can take the animal out on some walks. Some people choose to hold the animal up in their arms. Others use leads. It's important that they not be allowed to get very close to other people, strangers, or other people's pets, unfortunately, under these circumstances. But there's a lot that one can do in the home, exposing the animal to interesting smells, surfaces that they can walk on, strange noises, physical handling of the animal, taking the animal in cars, making it all as much fun as possible. So this is important if we're having to sequester these animals and reducing their opportunities for conventional socialization. In addition to the RSPCA, there's also a very good one from the PDSA and others available. Now, our next priority, lower but still important, is to protect the animals under our care against potentially life-threatening diseases that are prevalent in our particular areas. So where I live up in the northeast of Australia, it's actually a little microclimate that's fairly dry. But a fairly short drive north of here, in a place called Tully, the boss of the practice, the vet practice in Tully, tells me that sometimes in a very wet season, he might see 20 cases of leptospirosis in a fortnight, 10 in a week. And so that's a remarkably high prevalence of a potentially fatal disease. And obviously, using a risk-benefit analysis, then that would be a very important disease for him to protect animals against. And in fact, arguably more important than the core diseases, although I do think the very young animals need to be thoroughly protected against those core diseases. So here we're talking about a non-core disease. Not every animal in the world needs to be protected against leptospirosis, but extremely important in perhaps your neighborhood where you work. So most non-core vaccines need to be given every year to provide sufficient protection. And so in the case of leptospirosis, it's going to come up more frequently that we need to provide that protection. So what to do if, very unfortunately, lockdown, perhaps it's for a second or a third time, is put in place just when you were hoping you would be able to provide an annual revaccination against leptospirosis. The advice is that these vaccines can provide protection for a little over a year, in fact, perhaps 15 months. So if it is more than 15 months since the last leptospira vaccination was given, if unfortunately it's gone more than 3 months beyond the due date, the suggestion by the BGG is that 2 doses need to be given 2 to 4 weeks apart. In other words, we go back to the beginning and provide a prime boost. But if it's inside that period of 15 months, if it's only a month too late, then a single dose is satisfactory. Now, for puppies, thinking back to the fact that some vaccines, we do require a prime and a boost. For some puppies, if they get partway through this process, and then unfortunately we go into lockdown and it cannot be finished, then we have to go back to the beginning for those puppies. There are other potentially fatal non-core diseases. I won't go through all of the different ones. In the case of cats, FIV, the big risk there is going outside and getting bitten. And so under those circumstances, if the animal can be kept away from that risk, then we can not worry so much about continuing protection. And as Michael Day wrote in the draft about the advice on which actually Mike Lappin was also an author, then keeping the animal sequestered until such time as you can get back to the veterinary practice would probably be sufficient under those circumstances. And then much lower priority. This is an important point. We need to decide how we expend the resources that we have. So if time and the ability to see people in the practice is a resource that can't be squandered, then this would be lowest on my list of priorities because the core vaccines in both dogs and cats, particularly in dogs, are very long lasting. So if a puppy is properly protected with its last puppy vaccination after maternal antibodies have waned sufficiently, then it will be robustly protected for at least 3 years. And that 26 to 52 week injection vaccination is to catch the minority that failed to respond even when they got their last puppy kitten shot at the right time. After that, every 3 years is very prudent. Every 3 years is more than what is really necessary. The long-lasting protection is provided. And so I think these animals you can leave lower down in your list of priorities. And even lower, now we're talking about actually being not indicated at all, is the idea of using one of the dog or cat coronavirus vaccines in hope that you will get some sort of protection against the SARS-CoV-2 virus. Now, the diagram on the right is a sort of a family tree of coronaviruses. And the further you have to go from your place to find another virus further down the list, the further you have to go, the more distantly related. So if I tell you that canine enteric coronavirus is right up at the top of the pink, and that SARS-CoV-2 is down near the bottom of the yellow, it's an extremely long way to get from one to the other. They are very distantly related. Even the respiratory coronavirus of dogs, which is a beta coronavirus, only has about 37% homology at the amino acid level with SARS-CoV-2. So they are so very distant, even though they're both coronaviruses, they are so different one from the other that there's really no reason to believe that any useful protection would be provided. In any case, the coronavirus vaccines, the FIP vaccine that's available in some countries, and the canine enteric coronavirus vaccine are not recommended, designated as not recommended by the VGG. And the canine respiratory coronavirus, there is not a vaccine available commercially for that virus. And just to finish up, on the last slide or two, talk about things other than vaccines, prophylactic vaccines. Regarding heartworm and other nematodes, I think that it's unlikely that you would not be able to provide owners, or owners would not be able to get access to worming medications for gastrointestinal worms. Regarding heartworm, the American Heartworm Society recommends that testing be done every year. This isn't done in every country, but that is their recommendation. But under the circumstances of the COVID-19 crisis, the suggestion is that if, unfortunately, again, a lockdown occurs at just the wrong time, you're just due to get your animal tested and perhaps get the injection, the preventative injection for 6 months or a year, that it is okay to delay for up to 6 months, to carry on with the preventative for 6 months and not test if it's simply not possible to test. And that providing mosquito repellents or insecticide during that period, there are products now available to discourage mosquito bites, would reduce the risk of another animal getting infected by heartworm if, unfortunately, your client's animal had already become microfilariemic. If the lapse is longer, then the suggestion is that you could still carry on providing the preventative medication. But if it gets beyond about 6 months, then their recommendation is that preventative medication not be withheld, not be given until the test can be done. Now, I think in some other countries, once again, using risk-benefit analysis, in some other countries, then it may be that decisions would be made to carry on with preventative indefinitely because the risk of the animal being infected was that much smaller. And finally, my last slide before I hand over to Peter, there are many, many other interesting preventative healthcare measures that are being adopted by some practices. I think some of these, the boundary between preventative procedure and therapeutic procedure is quite porous or broad. Take dental prophylaxis. You know, if we decide to delay and then delay again dental prophylaxis, then it actually would become a therapeutic procedure rather than a preventative procedure because of the development of the periodontal disease. It's going to be very interesting if this continues for a long time to think about how using that risk-benefit analysis and prioritizing, we might decide how to behave with animals that would normally be getting cardiovascular investigations such as Holter monitor use or echocardiography to try to detect occult cardiomyopathy and that sort of thing. There's quite an interesting article on, do we really want to postpone preventive care? I think for many of us, this has been something that the local jurisdiction has decided for us, but I certainly think there's plenty for us to think about as we move into the future. So that's it from me about preventative healthcare steps. And I'm just going to go on to the next slide and hand over to Peter. You there, Peter?
I am. Thank you. Thank you, Richard. And thank you, Michael, for that very informative update. And thank you to WSAVA for allowing me to be part of this webinar. My role here is to give you a little bit of a perspective from the human medicine side in terms of what we're seeing in terms of the impact on human health. But also in the last part of my presentation, what I will hope to do is to give you a somewhat practical set of guidelines or approaches to how do you deal with potential exposure to COVID-19 in your workplace. How do you protect your staff? How do you protect yourself? How do you protect your clients? So with that, just a very brief overview. Some of this already has been covered, but as we know, this is a single-stranded positive RNA coronavirus. Initially started with an outbreak at a Hunan seafood market in Wuhan, China, in late December. And it's sobering to realize that last week, this past week, marked the 6-month anniversary of the World Health Organization designating SARS-CoV-2, COVID-19, as a world pandemic. And as Michael pointed out at the outset, that we are far from being close to seeing an end to this. And I think until we have a reliable vaccine, we will be seeing more and more cases. And there is great fear that, especially in the Northern Hemisphere, with the onset of cooler weather, less social distancing, people spending more time inside, we will be seeing spikes in cases. This is also probably enhanced by the fact that, as was pointed out by Richard, that there is great political pressure in countries to start bringing life, quote, back to normal, end quote, both for social reasons, but also for economic reasons. And as we're seeing schools reopening, restaurants reopening, we are, at least in the United States, certainly are seeing new areas of what we call hotspots. So we talk about initially about something called the R0, which is the reproduction factor for the virus. It essentially is a measure of how infective the virus is. And for the SARS-CoV-2, the R0 was estimated to be somewhere between 2 and 2.7, which means that in a population that has no immunity to this virus and no measures have been taken to try to mitigate exposure, one person who has SARS-CoV-2 is then likely to go on to infect 2 to 2.7 other people around them. In comparison, traditional seasonal influenza has an R0 value of 1.3, so it's much less than that. So this is not a complicated infection in the sense that we know exactly how this spreads, which makes it so unbelievable at times that people will not adhere to fairly standard measures for trying to prevent this. This is a respiratory illness. We know that this is an illness that's spread through respiratory droplets, either through people coughing, sneezing, talking loudly, and singing. There was much debate early on whether this is a disease that can be contracted through surface contact, and it probably can be. There is data that if you, let's say, touch an infected surface and then touch a mucous membrane, you can transmit you can become infected. However, this is not considered to be the main source of infection. This is really a respiratory illness. One of the things that's been fascinating for us in the human medicine side is that we are learning so much every day about how this disease presents, meaning what kind of symptoms people have. And one of the things that's been truly fascinating but also scary about this illness is that we've never seen an infectious disease that has had such a myriad of potential presenting symptoms. So the classic symptoms of most respiratory illnesses, and this certainly is one of them, is cough, sore throat, shortness of breath, fever, and chills. But we've also had patients presenting with severe headaches, severe myalgias. Loss of sense of taste and smell is considered to be pathognomonic for SARS-CoV-2 infection, and a lot of gastrointestinal symptoms. What finally makes this truly challenging is that we now know that about a third of patients who have COVID-19 are infected with COVID-19 may be truly asymptomatic. Now, one of the questions is, are they really asymptomatic, or are their symptoms so mild that they just don't report them? But this is a concern because it makes it very difficult to come up with measures for isolation because it's very hard to isolate someone if you don't know they're infected because they don't have symptoms. What we do know is that in many patients, they may have a mild flu-like symptoms. In others, the disease can progress to full-blown respiratory failure and death. And as was pointed out, at this point, we're almost close to 30 million people infected in the world, with almost 1 million deaths worldwide. And I think it's a fair statement that those numbers are probably an underestimation of the true mortality associated with this infection, simply because many of the people who've died of this disease never got tested. And then we also have to think about the collateral damage from COVID-19, which is that we're seeing people being afraid to go to the emergency rooms, being afraid to go to their doctors for treatment of the bread and butter, the usual types of medical illnesses that we see folks for, like strokes and heart attacks and other infections. And so we know that there are many people out there who've succumbed to routine medical illnesses simply because they've not had access to care because either it wasn't available or they've been afraid to seek it. Symptom onset is 3 to 7 days, with a median of about 4 days. Most people who have COVID-19 have very mild symptoms. About 14% have severe disease manifesting with hypoxia, or 50% of lung involvement based on imaging. And then about 5% have critical illness requiring intubation, mechanical ventilation, shock, and a multi-system organ failure. We at this point know that there are certain risk factors that make it much more likely that someone will have a more severe course and potentially a much worse outcome. This includes older age, people with cardiovascular disease and hypertension, people with chronic lung disease, diabetes mellitus, chronic kidney disease. Obesity, interestingly, has been shown to be an independent risk factor for worse healthcare outcome in this infection. And in the United States, we know that the Latino and the African American population is at a much higher risk of developing, not only being infected, but also having a much more serious healthcare outcome. And why this is not totally clear. I think we know that there is definitely folks in that population group are much more likely to be employed in jobs where they may have much more closer contact with other workers. They may not be in job situations where they have the liberty of working from home. We do know there is much poor access to healthcare in that population group, and there may also be genetic factors that may be playing a role. In terms of complications, well, pneumonia is probably the best well described. Acute respiratory distress syndrome is a known complication, but we've also seen some unusual complications of this infection, including severe cardiomyopathy, people with no pre-existing heart disease, including fairly young and robust, people who develop full-blown cardiomyopathy and heart failure. We've seen severe thrombotic and thromboembolic complications, including pulmonary embolism, strokes, peripheral limb ischemia. We've also seen severe inflammatory complications. You may have heard of this term of a cytokine storm or cytokine release syndrome. We've seen autoimmune neurologic complications such as Guillain-Barré, and in children we've seen an inflammatory vasculitis involving the vascular system called Kawasaki disease. And I mentioned the delayed care for non-COVID illnesses. We also can't underestimate the impact of loneliness, anxiety, and depression in terms of the toll that these have taken from social isolation. One of the things that we've seen, which is really unfortunate, is at least in the United States, but my understanding this is true in most other countries, is that patients who've been hospitalized with COVID-19 are spending their time in a hospital alone, and they're dying alone because their loved ones are not allowed to see them in the hospital. Now, in the United States, that's been relaxed somewhat, but at the peak of the infection, especially in places that were hotbeds like New York City, for example, the tragic stories of people dying of COVID-19 without the ability to have a loved one there to hold their hand, and the impact that this has on the psyche of their family members cannot be underestimated. We've seen an increase in domestic abuse during this pandemic, and of course, the other impact is unemployment, and the impact that has on access to healthcare, and especially in countries where healthcare may be access to healthcare may be based on employment, such as in the United States. This is an example of a COVID-19 related pneumonia. This is just one example. We've seen anything and everything you can imagine in terms of radiologic patterns, but the classic COVID-19 pneumonia pattern is this peripheral, patchy ground glass opacities. Now, I'm not the first person to note that treating or learning how to treat patients with COVID-19 is a little bit like building a plane in flight. We really are learning as we go along because we've never seen a disease like this before. And a lot of the strategies that we traditionally use for treating patients with pneumonia and adult respiratory distress syndrome may not apply in COVID-19. So, for example, typically when we see somebody in full-blown respiratory failure who's hypoxic and they're hungry, it's a pretty standard protocol for intubation and initiation of mechanical ventilation. Well, we're learning with COVID-19 that may be the wrong thing to do, because once somebody is intubated and on mechanical ventilation, now we introduce a host of other potential complications. These patients need to be paralyzed to control their ventilation. They now have a plastic tube down their throat, which increases the risk of hospital-acquired pneumonia, sinus infection, bed sores, so on and so forth. So we now are learning that what may be much better is to delay intubation, treat these folks with very high flow oxygen, and use non-invasive ventilation. We're also using prone ventilation. Traditionally, patients, humans who are on a respirator are on their back when they're ventilated. Well, we know from some earlier studies with ARDS is that there may be a role for prone ventilation, meaning ventilating people on their while they're on their belly. The change in distribution of ventilation perfusion improves, and you can improve oxygenation and ventilation in these patients. Also, the traditional mode of ventilation for folks with ARDS, or adult respiratory distress syndrome, is to use very low tidal volumes and high positive end expiratory pressure, because we know these folks have what we call stiff lungs. Their lung compliance is poor. Well, this may be applicable in some patients with COVID-19 pneumonia who have ARDS, but we're also recognizing that there's another subset of folks with COVID-19 whose lungs are very compliant. They are not stiff at all, and these ventilation strategies may not be the right way to go. And then we get into novel treatments, and I'm sure you've heard many of these, and you know, the jury is still out on what actually works, because the studies have been somewhat limited. You probably heard initially the potential role of use of hydroxychloroquine with, I apologize for the typo there, azithromycin, showing potential decrease in infection rate with COVID-19. That, I think, has at this point been discounted, and there's concern that hydroxychloroquine and azithromycin have potentially dangerous impact on the cardiac conduction system, leading to arrhythmias. So we're staying away from this treatment at this point. Remdesivir has been shown to be promising in decreasing length of stay and hospitalization. We've seen some use of interleukin-6 inhibitors. There's been some preliminary data that convalescent plasma from patients who've recovered from COVID-19 and have antibodies may be helpful. There's some interesting studies on the use of corticosteroids, and that has been shown that potentially use of corticosteroids in patients who have respiratory failure may improve their survival. And finally, anticoagulants are being used quite frequently just for that very specific reason that I mentioned earlier, that we know that many of these patients tend to be hypercoagulable. I'm going to skip over this, I think, because this was already described in detail by Michael Lappin. In a nutshell, this is a reverse zoonosis, and we do not need to worry about passing this on to pets. As a matter of fact, it is important for us to remember, and we do as members of WSAVA, that the human-animal bond is so critical for human and animal welfare, and that for many folks who are living alone with this illness or are isolated, pets may be the only family member they have that they interact with. this is a really interesting paper, and I just put this up because, you know, we talk about zoonotic diseases so much, and we sometimes forget how information is presented to us, and then we sort of forget about it. And this was a paper that was published in 2007 from a group in Hong Kong that was studying SARS, and pointed out that exposure to, there's a reservoir of SARS-CoV-like viruses in horseshoe bats, and linking that to that exposure to wet markets in that part of Asia, and the potential risk for potential pandemic. It's as if they could read the tea leaves. I think I'm going to, I think I'm going to skip over this in the interest of time because Mike already covered this. And I think what I'm going to do is just finish off with some practical points that you can use in your practices. And I need to start off with a caveat that these are practical recommendations that are based on our current knowledge of how the disease is transmitted. A lot of this comes from the United States Centers for Disease Control and from World Health Organization. It's important to remember that this being obviously an international audience, that you have to also rely on your own local health and government recommendations. So here we go. So first of all, I think that masks for all clients is a must. As I mentioned initially, this is not complicated. This is a respiratory illness, and it's been clearly shown that masks decrease disease transmission significantly. Unfortunately, in some parts of the world, the United States very much one of those places, mask wearing has been politicized, and there have been situations where veterinarians have had pushback from clients on mask wearing. I think that it's important to make this a policy of your practice, although I can see how this could be maybe difficult to enforce depending on where you are. You want to limit the number of clients in the practice to maintain a 6-foot or 2-meter spacing. Consider drop-off service, and this was actually very effective, and it's still being practiced in many veterinary practices in the United States, where clients drive up to the practice. They call the practice on their cell phone. A practice member will come out wearing a mask, pick up the pet, take the pet into the practice, do whatever needs to be done in terms of treatment, and then the client either waits outside or is told when to come back. So there is a significant decrease in the number of clients in the office. You might want to screen your clients for symptoms prior to entering the building and inquire about recent travel to endemic areas. What about your staff? Well, there's some debate about this. Ideally, you should have your staff wearing a mask at all times. Surgical masks are fine. You do not need to wear an N95 mask. Now, if you have unlimited access to an N95 mask, great, but a lot of places do not. As you know, an N95 mask is supposed to filter out at least 95% of respirable particles. But the thing you need to remember is that in order for an N95 mask to really work properly, it has to be fitted. There isn't one size fits all. And in the human medicine world, those of us that use N95 masks have to be fitted, meaning that you have to find the right size. For men, technically, you should not have any facial hair while using one. And any of you who've actually used a well-fitted N95 mask, you know that it really is pretty uncomfortable to breathe. And so as a general rule, we don't even recommend N95 masks in the hospital unless you're going to be doing some type of a procedure where you will be exposed to significant amount of respiratory droplets. That would be intubation, doing laryngoscopy, or doing bronchoscopy. But for routine contact with patients, an N95 mask is not necessary. Face shields alone are not protective. So you will hear folks saying, oh, I just can't breathe through a mask, but a face shield is okay. There's a great YouTube video that you can pull up that shows respiratory droplets. They're colored, so you can, and it's in slow motion, and you can see how somebody coughing or sneezing just spreads the particles underneath and around the full face shield. So a face shield alone is not adequate. Wash your hands, but you're veterinarians, so you do that anyway. Consider disposable glove use if you have a large supply of those. You really want to encourage the staff to report symptoms. You don't want to create a culture that's punitive. You really want to know if somebody's getting sick, because remember, if somebody in your practice is sick, technically you're going to be quarantining your entire practice. There is some potential role for daily monitoring, temperature monitoring of your staff. We do that in my office, for example. And you may want to consider staggered shifts or dedicated teams so that if someone does come down with COVID-19, they're only potentially exposing a limited number of your staff members, so that if you have to then quarantine, you're not quarantining your entire staff, you're quarantining a fraction of that staff. What about your facility? Frequent sanitizing of high-touch surfaces. So any type of a alcohol solution that is at least 70% alcohol will work. Diluted bleach will work. Anything that improves ventilation. Now, this can be as simple as opening a window to the other extreme, which may be very expensive, which is installing a high efficiency filtration system. You will want to install barriers between clients and your staff, especially at the checkout desk. This can be a plexiglass sheet or plastic sheets. It doesn't have to be complicated. And you want to post clear instructions and expectations for your clients at the entrance, so there are no surprises. Now, some of these may be available from your local health department, but you may also wish to add your own specific instructions, such as you cannot enter this practice unless you're wearing a mask. What do you do if your staff becomes ill? Well, you want to encourage your staff to report symptoms. You don't want to be the last one to know that somebody is ill. If you have the ability to get your staff tested, you want to get them tested and not have them return to work until the test results are available. Now, I know there's a lot of controversy about testing, and the biggest problem that we've run into is the turnaround time for test results. Obviously, if you can't get the test results back within 48 hours, they may not be very helpful. If somebody has known COVID-19 exposure, you want to have them quarantined for 14 days from the time of exposure. If somebody actually tests positive for COVID-19, they need to quarantine for at least 10 days after symptoms first appeared and at least 24 hours passed since the last fever occurred without the use of antipyretics. And I think with that, I will end my part of this talk.
Thanks very much, Peter. David here. You can hear me okay, can you?
Yes.
Good. Okay. We've had a number of questions come in, and so what I'll do is, in the interest of time, I think we've got time for sort of one question for each of you. They've divided themselves out quite neatly into that area. First off, Mike, we've had a few questions on testing pets for SARS-CoV-2. So the gist of it is, what are the tests that are recommended? Are they the human rapid tests that are used for pets? We've also had a sort of related question about whether the feline infectious peritonitis test has any cross-reactivity in this respect. And also the advisability of testing and should we be testing pets for this? So I'll throw those over to you if I can.
Yeah, fantastic questions for those of you that posted those. Thank you so much. Honestly, we would have to have an entire hour to do justice to that group of questions. But bottom line is we can basically amplify the RNA, and we do need to use specific tests for SARS-CoV-2 in the PCR reactions. We can grow the virus or isolate the virus, which would then prove that there's still live virus. And then we can use antibodies that says basically the immune system has seen the virus and mounted a response to that. What we're sorting out right now is what are the best targets for the antibody tests. And as you've probably read in the human literature right now, there's a bit of a problem with the RNA PCR, RT-PCR amplification, because now we know that a person can have the RNA of the virus, but no longer have live virus. And so right now we're still in the figuring out what's the best way, which tests are the best to use. But again, back to most of us today are probably clinical veterinarians. The good news is the limited amount of studies we have so far is live virus is shed for a very short period of time, which was my point earlier that here we are all clamoring for tests, but perhaps by the time you got approval to do the tests were actually performed, the animal is no longer going to be shedding by the time you get it back. And then there's the problem with using the RNA-based tests that you could have a positive and the animal not be infective. So it is a quite controversial and difficult time for us in clinical practice. But the data does suggest that for the relatively healthy animal that's exposed from their owner, the disease should be mild and short-lived. So that's the good news while we sort out best practices in the coming months. But thanks for that question, David.
That's great. Thanks very much, Mike. That's yeah, good. It's a complex area, and as you say, it would probably take half a day to discuss fully. But thanks for that concise response, Richard. A question for you, and I think you covered this well in your presentation, but it's quite an important issue, and we've certainly had questions on this. And it's really to do with whether the coronavirus vaccine for dogs is going to give any form of cross-immunity against SARS-CoV-2.
Okay. Well, as I mentioned before, although they're both coronaviruses, they are very far apart. If we think of another virus family, I once read something long ago suggesting that the difference between two lentiviruses was akin to the difference between a human being and a mushroom. Now, I never checked those details out. It seems dramatic, but the point is that, you know, if we are 99% the same as chimpanzees over a number of genes that we share, and 96% overall because the rubbish DNA or the garbage junk DNA is not shared, these viruses, because they evolved so quickly, have diverged dramatically. So you see them on a family tree and you think, well, you know, it might provide some, why not? You know, it might provide some benefit. But I think the answer is absolutely not. They are as different as chalk and cheese. They are more different than chalk is from cheese. And you should not assume that there will be any benefit whatsoever in terms of protecting them against this virus. And as Mike has repeatedly made the point. As virus seems to have difficulty infecting dogs and causes very little illness if it infects them at all. So I strongly recommend against it.
Thank you. Thank you very much, Richard. That's clear. Peter, I had a couple of questions about masks and sort of best practice, I suppose. As far as the sort of surgical masks are concerned, a question about how many hours of use would you normally allow for a surgical mask, and how frequently should they be changed?
That's a great question. I think the short answer is it really depends on your availability. Ideally, you probably would want to change the mask at least twice a day, but that may not be practical in some places. The other is any type of soiling of the mask. You obviously have to change that mask immediately.
Okay. And another quick question on masks. The N95 mask that you mentioned, is that something, you said it has to be specially fitted? Is that something which is fitted
Yes.
just once, or does it have to be redone each day? You put it
No,
on?
no, it's a one-time fitting. They come in I believe in 3 different sizes, and you need to be fitted just once. But the way that's done is with what's called a fit test, where you're actually being exposed to a smell, and you have to be able to tell whether you can or you can't smell it. So it really should be done once, should be done well, and then after that you know what size you need. But you really don't need. We don't think you really need an N95 mask. Unless you are in a situation where you know you're directly being exposed to the virus and virus droplets. One thing I didn't mention, which I just want to point out, is that you'll see a lot of these masks with exhalation valves to make it, quote, easier to exhale. And we do not recommend those because you really are trying to protect the other person more so than yourself. So ideally you want both sides of of both people having a mask on at the same time, but having the exhalation valve totally negates any protective value to the other person.
Yeah, okay, that makes sense. Thanks very much for that. Okay, well, in the interest of time, we've had a number of questions which we'll capture as part of this process anyway, but which we haven't been able to get to. But we've covered off some of the common areas, I think, that have featured in the question list. So thanks very much indeed. It remains for me now, I think, to bring this webinar to a close. And so I'd like to, on your behalf, audience members, and also on behalf of MSD Animal Health, I'd just like to say a huge thank you to our distinguished expert presenters today. I think everyone will agree you guys have managed to cover this increasingly broad and increasingly complex area in a clear and informative manner. So many, many thanks indeed to Dr. Michael Lappin, Dr. Richard Squires, and Dr. Peter Karczmar for their really excellent presentations. I think you've done a fantastic job. You've covered a lot of ground, given us a really good update. So I'd really like to say a huge thank you for all the effort that went into preparing and presenting those. So thank you very much. Okay, so beyond that, a recording of this webinar is going to soon be made available, and it'll be available from the COVID-19 Advice and Resources section of the WSAVA website. So if you missed any part of today's session, you will be able to catch up with it there. So that'll be available shortly there. And there will also be translated transcripts into some of the major languages, if your native language isn't English. So you will be able to catch up in some detail if you weren't able to follow any of the presentations as easily as others on this session. The last big thank you, of course, is to all of our attendees. Thank you very much indeed for your interest and for joining this webinar. It makes it very much worthwhile, obviously, with the numbers we've had. We hope this was of help and interest and will provide you with the information you need to manage your business and the needs of your clients and their pets during these certainly unusual times. So thank you all, to speakers, to audience, and of course to WSAVA for your interest and for allowing this to be hosted under the WSAVA umbrella. Thank you very much indeed.